Alrighty, good morning, guys. Today's lecture is going to be covering chapter 21 and 22. Because of where I'm recording these lectures today and the connection, I am not going to use the PowerPoint on the screen. So what you can do at home while you're listening to this is go ahead and put on your recording, start playing me in the background, and just follow along with your PowerPoint as you're going through this. I will flip back and forth to the PowerPoint, but I'm going to stay on the screen so that I can see if the audio cuts out and just stop talking so I don't have to go back and re-record myself. All right, chapter 21. Vital signs. We're very familiar with our vital signs as we practice them in the lab this week. You guys are all now competent and checked off on assessing all 5 vital signs, including pain. So we know that, of course, our 5 vital signs are temperature, pulse, respiration, blood pressure, pain level, and oxygen saturation. These give an indication of a person's health, and they represent the interrelated physiologic systems of the body. If you assign another healthcare worker to take vital signs on your patients, always go back and check their measurements to see how they fit with your assessment and the overall picture of the patient's health. It's also important to check them to see if there's any mistakes, because we know at the end of the day we are responsible for that. So the overview of structure and function, we're going to kind of breeze through that. You guys should remember these concepts from structure and function. We will remember that metabolism is a byproduct of heat production. When our metabolism increases, more heat is produced, and that is how a fever happens. Our basal metabolic rate is the rate that heat is produced when our body is at rest, and our average BMR depends on the person's body surface area. Our BMR is affected by the thyroid hormone, and we know that our temperature is regulated primarily by the hypothalamus, which acts as a thermostat and controls our body temperature through a series of feedback mechanisms. We can review the ways that heat is lost from the body with the 4 routes: radiation, conduction, convection, and evaporation. We know that blood flow to organs carries, and air movement causes heat to be transferred from the skin to the air molecules by convection. This can happen with a fan cooling by convection. Heat loss will increase when the skin is moistened and evaporation occurs. Pyrexia is the medical term for a fever, and we know that when pyrogens, like bacteria, cause an immune response in the body, the hypothalamus will be stimulated to raise the body's temperature and cause a fever. Diaphoresis is the medical term for excessive sweating, and hypoxia we know is the state of not having efficient oxygen, so insufficient oxygen. How do we control our pulse? We know that cardiac contractions control them, and our cardiac contractions are initiated by the SA node, which is the heart's internal pacemaker. When the heart contracts, about 60 to 70 mLs of blood is propelled into the aorta, and our stroke volume is the volume of blood pushed into the aorta with each heartbeat. Your stroke volume affects the character of your pulse, and a weak pulse could indicate a fall in your stroke volume. Cardiac output is the pulse rate multiplied by the stroke volume. This is the amount of blood pumped by the left ventricle in 1 minute. The average for an adult should be 5 liters of blood per minute. You'll remember that respiration is a combination of 2 processes, external and internal respiration. The nose, pharynx, larynx, trachea, bronchi, and lungs are the organs of the respiratory system. We know that breathing is an involuntary automatic function, which is controlled by our respiratory center located in the pons and medulla within our brainstem, and that respiration is controlled by feedback mechanisms. Blood pressure is the pressure exerted on the arterial walls. Our systolic pressure is the maximum pressure exerted on an artery when the left ventricle contracts, or systole sends the blood out into the body, and diastolic is the lower pressure exerted on the arteries as the heart is resting and filling with blood during diastole, the time in between contractions. We know that cardiac output affects our blood pressure, as well as vasoconstriction and vasodilation. Being too hydrated or dehydrated will affect your blood pressure. When you are too overhydrated, your blood pressure will increase. When you are dehydrated, your blood pressure will decrease. The thicker your blood gets, the higher your blood pressure gets. And when your vascular walls lose elasticity, as happens with atherosclerosis as well as age, your blood pressure will increase. That's one of the reasons why our elderly population will typically have a higher blood pressure, because their systolic blood pressure will rise as the aorta and major arteries lose their elasticity. As well as with our elderly population, you will see temperature becoming a less reliable indicator of health. This is because they have a lower than normal temperature than the average adult due to a lower metabolic rate. The normal range for the heart rate should not really change in the healthy older adult, but the rhythm could be slightly irregular. The respiratory rate may rise slightly as decreases in vital capacity and respiratory reserve occur naturally with aging. Our normal body temperature should range from 97.5 to 99.5 Fahrenheit. This could be 36.4 degrees Celsius to 37.5 degrees Celsius. This does vary considerably among individuals. We measure our temperature in Fahrenheit and Celsius. Mainly here in the United States, we use Fahrenheit. You will get quite a few patients that will ask you what their temperature is in Celsius. It's very easy to calculate, and sometimes I'll just use my phone to do it for them real quick. The average temperature in a healthy young adult should be 98.6, although we know that this does vary with the normal range as the body adjusts to change in the environment in the amount of heat lost and produced. It's important to know the usual temperature measurement and then compare any changes with their baseline. The patient's temperature usually does not indicate a fever until it gets over 100.2. Within Baycare, we treat a fever once it reaches 100.4. The temperature reading obtained varies according to the site used, and we'll remember that from clinical this week. Measurement sites for temperature include the mouth, rectum, axilla or armpit, ear, and skin. The tympanic membrane is via the temporal artery. Rectal temperatures will usually be about 1 degree higher, and axillary temperatures are usually about 1 degree lower than those measured orally. The temporal artery thermometer is the most accurate, non-invasive way to measure body temperature because it passes over the temporal artery in the forehead. Arterial temperature is close to rectal temperature, but about 1 degree higher than oral temperature. Temporal artery temperature is unaffected by eating, drinking, smoking, or mouth breathing. Measuring tympanic temperature involves inserting the thermometer probe into the auditory canal. This is a good indicator of your core body temperature. Your core temperature is the temperature of the deep tissues in your body. Temperatures taken with a tympanic thermometer are not subject to any variations caused by eating hot or cold foods or liquids, smoking, or chewing gum. Tympanic temperatures can be infected by an ear infection, excessive wax blocking the canal, or someone with a small curved ear canal, like a child. Oral temperatures are often convenient for older children and adults. If the patient has recently swallowed hot or cold foods or has been smoking or chewing gum, you should wait 15 to 30 minutes for those effects to pass in order to obtain an accurate temperature. A glass thermometer is never used orally if the patient is uncooperative or at risk for biting the thermometer. We also know that glass thermometers are not utilized within Baycare. We use disposable thermometers and plastic. Rectal temperatures are taken when an accurate temperature cannot be obtained orally, and a tympanic or temporal artery thermometer is not available. Sometimes, realistically as well, your physicians will order rectal temperatures. In the ER, a rectal temperature is a very common order. We used to receive it all the time, especially on your patients concerned with any type of infection or sepsis. Rectal temperatures should not be used on patients with cardiac conditions or patients who have rectal surgery. Typically, it is the choice of last resort. Again, this is really going to depend primarily on where you're working, the type of population that you're working with. So it can depend on your facility as well as the unit that you're on. Within the ER, we did rectal temperatures very, very often. Axillary temperatures are typically a less reliable measure. Reason being is because they're going to be about 1 degree lower than your actual body temperature. So we can use the axillary temperature, but it's usually not very reliable. And if we can get a better route, we would try to do that. And we would want to treat a fever over 100.5. Hyperthermia is a condition in which the patient's temperature is above the normal range, so above 100.2, can be called a fever, a febrile state, or pyrexia. Fevers are typically not considered significant until the temperature reaches about 101.3. Hyperthermia can occur after brain injury which is one of the reasons why we go ahead and cool our patients. The metabolic rate increases by about 7% for each degree when you are rising in temperature. So as your fever goes up, your metabolic rate increases as well. Fever will occur in 3 stages: the onset, febrile, and defervescent stage. The onset can occur gradually or suddenly. The person will feel cold and add clothes or covers, curl up in a ball, and maybe turn up the heat to feel warm. They'll experience chills, increased respiratory rate, and increased pulse. During the febrile stage, the body temperature now rises to the new set point established by the hypothalamus, and it will stay there until the cause of the fever has been resolved. If the fever is very high, or if it lasts for an extended period of time, dehydration, delirium, and convulsions. We call this a febrile seizure. Dehydration occurs as fluid is lost with perspiration and more rapid breathing. Delirium and convulsions could occur due to the neurologic function being affected by the elevated temperature. The stage of defervescence begins lowering the body temperature back to normal. The person will feel warm and the skin could be moist. A crisis would be an abrupt decline in the fever, and it could return when the body controls the infection, or a lysis, which is a gradual return to the normal temperature when applied with a fever, could mark the decline of that fever. Fevers are typically classified as constant, intermittent, remittent, or relapsing. Hypothermia refers to subnormal body temperature. This is a lowering of the temperature of the entire body. The thermoregulating center in the hypothalamus is generally impaired when the temperature of the body falls below 95 degrees. Patients at risk for hypothermia include post-operative patients who have been cooled during surgery, newborn infants whose skin is exposed to cool room temperatures, older adults and debilitated patients, the chronically ill, patients taking certain medications, and those exposed to cold temperatures for prolonged periods, such as homeless populations. People exposed to extremely cold weather can suffer frostbite. If frostbite is prolonged, it can cause death of cells and loss of the frozen area. Nursing activities for treating the patient with a hypothermic temperature should focus on reducing heat loss and supplying them with additional warmth. Provide additional clothing or blankets for warmth. We use blanket warmers to provide warm blankets. Give warmed fluids, if permitted. You do need a doctor's order within Baycare to give warmed fluids. Adjust the temperature of the room to 72 degrees or higher, if possible. Eliminate drafts. Increase the patient's muscle activity and submerge any frostbitten areas in a warm bath with water temperature no warmer than 107 degrees. When we measure temperature, most healthcare facilities use electronic digital thermometers. We also use tympanic thermometers, temporal artery thermometers, and disposable single-use thermometers. When taking an oral temperature, the tip of the thermometer or probe should be covered with a plastic sleeve and then placed in the sublingual pocket in the mouth. Instruct the patient to keep the tongue down, close the mouth, and keep their lips closed. When taking a rectal temperature, be sure to provide privacy and ask the patient to turn on their side facing away from you with their knee slightly flexed. The Sims position can be very useful for this type of procedure. Lubricate the tip of the rectal thermometer or probe and insert the lubricated bulb into the rectum directly toward the umbilicus. Insert about 0.5 to 1.5 inches. When finished, wipe the buttocks to remove any lubricant or stool. When taking an axillary temperature, place the thermometer in the center of the patient's dry armpit. A wet armpit could produce a false reading. Your book goes over glass thermometers. I'm honestly not going to go through it very often because we do not use glass thermometers. The textbook even states the glass style thermometers are being used less commonly than previously due to the risk of them breaking and a length of time it takes to use them. Our digital electronic temperature thermometers that we use within the hospital, you'll get a temperature reading within 15 to 45 seconds. Your glass style thermometers, they're typically going to take anywhere from 3 to 5 minutes. So not really cost effective as well as not really effective with our time management strategies. Electric thermometers are portable, battery operated, and they register body temperature in 5 seconds to 1 minute. Really, this is also going to depend too on how well your patient is able to follow the directions. Sometimes it takes a little bit longer to get a temperature when they're not maybe putting the probe in their mouth the right way, or it's not positioned correctly, so that could be an issue as well. The correct disposable probe cover and correct setting should always be used on the electronic thermometer whenever taking an oral or rectal temperature. When using the thermometer, you'll see that it'll have a little arrow next to a person pointing to their face or pointing to their butt, and that shows you whether or not the thermometer is set for oral or rectal temperature readings. And it is important to have that correct for the actual temperature that you're taking. It does make a difference. The reading on electric thermometers will be in tenths of a degree, so the temperature taken may end in like an odd number, like 99.5, and that's okay. And you would just chart that as such in the computer, not round up or round down. Tympanic thermometers are portable battery-operated electronic thermometers that register temperatures in 1 to 2 seconds. The temporal artery skin thermometer is moved over the skin of the forehead directly over the temporal artery. It's an electronic thermometer that is fast and very accurate. It's also less invasive than the tympanic thermometer, and it's more reliable when used correctly. We have various types of single-use disposable thermometers that are available, and among them are temperature-sensitive tapes that are placed on the forehead or abdomen to record the heat of the body. Directions on the package will explain how to use these disposable thermometers. When assessing your patients, always choose the appropriate site for temperature measurement. This is going to be based on the patient's age, the condition, and the type of thermometer you have available. Check the electronic thermometer battery before measuring the patient's temperature. A low battery could result in an inaccurate measurement. Abnormalities found on the assessment of other vital signs, pulse, respiration, and blood pressure, could indicate problems in various body symptoms. Always take the patient on admission to the healthcare facility so that a baseline comparison for future measurements is available. Take all vital signs according to your primary care doctor's orders or agency standards. Vital signs are typically taken every 4 hours when a known infection is present, every 2 to 4 hours when a fever is present, whenever the patient is not feeling right, whenever the patient is receiving medications that could affect their temperature or any vital sign, before surgery or an invasive procedure, and then at regular intervals afterwards as prescribed by a hospital protocol. Now, I've told you guys how I feel about vital signs, and vital signs should be taken every single time you're in the room before all medications. I don't care if they're ordered 4 hours. I don't care if they're ordered every 8 hours. If you're in the room with that patient for more than 60 seconds, you have time to take a set of vital signs. You should do it. Always evaluate measures to keep your temperature within normal range by analyzing the temperature trends on the graphic record. On page 362, there are some nursing interventions to reduce fever on box 21.3. Those are some really great interventions for you to look over. Measuring the pulse. Every time the heart contracts and forces blood into the aorta, the arterial walls in the vascular system expand and accept the increase in pressure. The pressure wave causes this expansion is called the pulse. By counting the pulsation of the arterial wall, we can determine the pulse rate. We know that the pulse can be felt wherever a superficial artery can be held against a firm tissue or bone, and it's felt most strongly over certain areas, such as the radial artery in the wrist, the temporal artery in front of the ear, the carotid artery on the side of the neck, femoral artery in the groin, the apical pulse over the apex, pointed end of the heart, and the popliteal pulse behind the knee. The pedal pulse of the posterior tibial artery on the inside of the ankle, and the dorsalis pedis on the anterior aspect of the foot. When it's difficult to find or count the radial pulse, the apical beat of the heart should be counted for a full minute with the use of a stethoscope. Count the apical pulse when it's important to have an accurate measurement of the heart rate, or when ordered by the primary care doctor for any patient with a cardiac condition. Routinely take an apical pulse prior to administering any digitalis and beta blocker medication. The apical, rather than the radial pulse, should be taken on children younger than 2 years old. Locate the apical heart sound by placing your stethoscope on a point midway between the imaginary line running from the middle of the left clavicle through the left nipple in the 5th intercostal space. And you guys can all correctly identify the apical pulse as shown in the skill time. The pulse rate will vary widely, and it's influenced by a large number of factors. Tachycardia will refer to a pulse greater than 100 beats per minute. Bradycardia will refer to a pulse less than 60. The average pulse in an adult is about 72 beats per minute. Medications can be prescribed to speed up the pulse or slow it down when it's too fast or too slow. Occasionally, you might need to take a radial pulse and an apical pulse when the radial pulse is irregular, skips beats, or is difficult to count. In this situation, you would use two people to count the radial and apical pulse deficit, and you guys all know how to do that as evidenced by your skills in clinical last week. As the blood travels farther away from the heart, the distinct wave of the pulse begins to fade, but the pulse can still be palpated at the ankle or top of the foot. Pedal pulses should be checked to determine whether there is any blockage in circulation in the artery up to that point. This is especially important in patients who have had a cardiac catheterization or other procedures involving the femoral artery for insertion of the catheter, or those who have had surgery on a leg. It's important to mark an X on the skin over the spot where you can feel the pedal pulse, so that all staff who come to assess that patient can use the same location. When the pedal pulse is difficult to locate, you can use a Doppler ultrasound stethoscope. A picture of the Doppler can be seen on page 366 in figure 21.12. So checking the pedal pulse is very important, especially after patients who have had a cardiac catheterization that went through the groin. The nurse would want to assess that patient's pedal pulse. When counting a pulse, we'll remember from the Sims lab that you need to not only note the rate, but also the rhythm and the volume or the amplitude. Begin by timing with a beat that is not counted, and then the next beat would be number 1. An arrhythmia or an irregular pulse has a period of normal rhythm that is broken by periods of irregularity or skip beats. A continuing arrhythmia could be indicative of heart disease or a medication's side effects and should always be reported to the primary care doctor, as well as documented within the medical record. Factors affecting the pulse rate can be found in the table 21.2 on page 366. I'd also like you to take a look at table 21.3 on that page with the average pulse rates. And please take a look and take notice of the changing of the average pulse rates in between the age groups. Notice how the newborn has a much higher average pulse rate with 120 to 160. And of course, we know our normal adult range is 60 to 100. So considering those factors when taking care of patients of all ages is very important. The volume or strength of the pulse is just as important as the rate. Some of the most common terms to describe strength of the pulse are listed on page 366. Weak and regular, strong in words like weak and regular, or sometimes you could just say your pulse is 1 pulse. Pulse rate and characteristics are assessment factors used to help determine a patient's overall cardiovascular health. Respiration should be measured every time a full set of vital signs is taken. A change in respiratory rate can indicate a change in the patient's condition, and it should always be considered along with other vital signs and assessment data. Count the respirations for 30 seconds and multiply by 2. Somebody who is very ill or has irregular respirations, count for a full minute. Many of the factors that affect the pulse rate also affect the respiratory rate because the heart and lungs are so closely connected in providing oxygen in order to sustain life. Respiratory rates will also vary with age. And you can take a look at the table on page 368, the normal range of respirations, and see the difference there between the older adult and then the newborn patient. Head injury or any increased intracranial pressure will also depress the respiratory center and result in shallow or slow breathing. If an adult does not breathe at a minimal rate of 12 depth, some of the following symptoms of hypoxia could occur: apprehension and restlessness, confusion, dizziness, and change in level of consciousness, cyanosis, which is bluish discoloration, or other skin changes, skin color changes, particularly around the mouth as well as the nail beds. As you count your respirations, you need to observe for any variations in the pattern of breathing. This is going to be the rhythm that we talked about and discussed in lecture as well as in the Sims lab. Eupnea is the term for a regular, normal, relaxed breathing pattern. We said that if a patient has a eupneic breathing pattern, they're breathing normally with any type of distress, you could count for 30 seconds times 2 or count for 15 seconds times 4. Dyspnea is difficult and labored breathing. This can often be accompanied by flared nostrils, an anxious appearance, and statements such as, "I can't get enough air." It is also important to know how much activity will cause the dyspnea. You can ask your patients about this. I can tell you from personal experience, when patients tell you they can't breathe, you need to listen to them. It's important. Bad things could happen shortly after if you do not make the appropriate interventions at that time. Tachypnea is increased or rapid breathing. The breathing rate will increase about 4 breaths for each 1 degree of increase in temperature. Bradypnea is slow and shallow breathing. Hypoxemia, as we know, is decreased levels of oxygen in the blood. Now, bradypnea can be seen in patients under medical attention, those recovering from anesthesia or abdominal surgery, or those in a weak or debilitated condition. You can also see bradypnea after patients come in with drug overdose, as well as patients who are postictal after a fever. Hyperventilation is a pattern of breathing where there's an increase in the rate and depths, and you expel more carbon dioxide, causing your internal levels of carbon dioxide to fall. We see this condition after severe exertion, high levels of anxiety or fear, and with fever and conditions such as diabetic acidosis. Kussmaul's respirations are seen in patients with diabetic acidosis and kidney failure. Biot respirations are 4 to 5 breaths of equal depth with irregular periods of apnea. These respirations will occur in patients with increased intracranial pressure. Stokes respirations consist of a pattern of dyspnea followed by a short period of apnea, so difficulty breathing followed by a short period of no breathing. Your respirations are faster and deeper, then slower, and are followed by periods of no breathing, and with a continuation of that type of cycle. The breathing pattern can be seen in critically ill patients with brain conditions, with patients with heart or kidney disease, as well as in cases of drug overdose. Then we have some of our adventitious or abnormal lung sounds. Crackles, formerly called rales, typically heard when there